This Let's Talk About Women's Health series has been brought to you by Tallaght University Hospital. These podcasts have been kindly supported by the Healthy Community section of South Dublin County Partnership. You're very welcome to this, our third episode. I'm Nolene Leddy, and on this podcast, we'll be talking about how women can cope with pelvic prolapse and incontinence. To learn more, I'm joined by Consultant Gynaecologist Dr. Aoife O'Neil, Specialist Physiotherapist Gráinne, and Cheryl Gilmore, an Advanced Nurse Practitioner in Women's Health. You're all very welcome.
Thanks very much, Nolene, and hello.
Thanks for having us, Nolene.
Hi, Nolene. Thanks for having me on.
So Aoife, first to you, what causes a pelvic prolapse and how is it diagnosed?
We see women coming to our service with what we call pelvic organ prolapse. And that is when there's a displacement or a drop in one of the pelvic organs, like your bladder or your bowel, or even the uterus itself, where it prolapses downwards, drops down into the vagina and causes a bulge in the vagina. And that usually is felt as a pressure or a little golf ball sensation that makes people worried because there's a lump there. And it has a number of different things that contribute to why somebody might get pelvic organ prolapse. But the biggest risk factor for it is childbirth. Mm-hmm. There are situations then that cause strain on the pelvic floor. Childbirth being the most obvious one. But things like chronic constipation, having a chronic cough where you're coughing a lot, if you have an asthmatic problem or a bronchitis problem, that can cause a lot of strain on the pelvic floor. It's interesting that sometimes a prolapse can run in families where your mum or your sister might have had prolapse and her daughter is at more risk of it. We think that might be because there's some deficiencies in the tissue collagen that makes people more prone to prolapse. And being overweight and obese has a contribution to make to why somebody might have prolapse. And in addition, especially if you have had exposure to severe pelvic strain, such as in childbirth, if you're in a job, for instance, that there's a lot of heavy lifting and you're not conscious of how that may be impacting on your pelvic floor, those are the types of things that you need to be aware of.
That can cause it. And how do you diagnose it?
So it requires an examination of the vaginal area. Very often when women first find that they have a sensation of something coming down in the vagina, they worry that this is a lump that is, of serious significance. And they often will, first person protocol to go to always is your general practitioner. And the GPs have a lot of experience in seeing people with prolapse. And what they do then is they ask for a specialist opinion from someone like myself in the Gynaecology department to examine and assess what kind of prolapse it is and how do we address it and what can we do for it.
And do you do that with scans or internal examinations?
Yes, so it involves having an internal examination, a gentle exposure of the lips of the vulva so that you can see what part of the vagina seems to be prolapsing downwards or dropping down. And very commonly it's the front wall of the vagina. That's the most common type of prolapse. But the uterus and the cervix itself can also be one of the organs that falls downwards in the vagina. And you can get a bulge on the back wall of the vagina, which is where the rectum, the lowermost part of the bowel, is bulging inwards into the vaginal area.
So I can understand that this must be extremely uncomfortable. Gráinne, as a specialist physiotherapist, can you tell us what exactly you can do to help women who are suffering or have had a pelvic prolapse?
So we would take kind of control over the conservative management of the prolapse with our nursing colleagues. So physiotherapy is mainly focused around strengthening the muscles that support either the bladder, the back passage or the uterus. And a lot of what we do would be involving in strengthening muscles to reduce the impact of that downward pressure of the prolapse. So we would see a lot of women who would not be going for surgical correction of this. And our main focus is to try to retrain those muscles to be able to control those organ functions a little bit better. That involves an internal examination, and it involves regular follow-up and exercise prescription by a physiotherapist to reduce the impact. And this is predominantly for those mild to moderate prolapse patients.
And could you give us an example of a kind of exercise that you might show a woman with a mild pelvic prolapse to do?
So if somebody has a mild pelvic prolapse, typically they wouldn't be for surgery and they would be more for conservative care. So we would often introduce pelvic floor retraining to those patients, and we would use visual and verbal cues to help them to recruit those pelvic floor muscles, because often women are unaware that, first of all, those muscles support the organs, but also how they function correctly. And it's really important that the woman would know how to get those muscles to work correctly. And the muscles tend to, if they're working correctly, tend to draw inwards around the organ and lift to support that organ. And most women, when they have a prolapse, have a susceptibility to dysfunction of those muscles, and they will often be downwardly pushing those muscles. So that's actually worsening the problem. So we will often use those prompts such as imagine that you're drawing those muscles inwards and upwards. We would use a lot of different visual cues, and we really find what works best for the woman from a visual or a verbal prompt, because these muscles are difficult for women to isolate, but they can work in isolation. And it's also difficult for them to not recruit other muscles as well while trying to contract their pelvic floor. So we will often get patients recruiting those muscles lying down, and then we will move into positions such as functional positions like walking or standing, because the symptoms of the prolapse is often felt when they are standing. It's not often as bad when they're lying down or sitting.
But the good news is that physio can help mild cases of prolapse.
Yeah, definitely. So physiotherapy can really reduce the symptom of the prolapse, which is, as Dr. O'Neil said, that heaviness, that pressure, that feeling of something coming down. So if that prolapse is a mild prolapse and you can get the muscles working properly to support that organ, then they will very much feel that there's no symptoms at all. And that downward heaviness can be diminished significantly. And we will also then teach them how to empty their bowel properly, how to empty their bladder without straining. And a huge proportion as well of what we do is teaching people how to breathe correctly, because the diaphragm which is the muscle we use to breathe, is very closely linked to the pelvic floor muscles. So once we have an identification of what muscles are dysfunctional, we can really hone our pelvic floor training to improve the function of the whole cylinder.
And sometimes a prolapse can cause incontinence. Am I right, Aoife?
Yes. So what I think a lot of people probably aren't aware of is that your bladder and your bowel are in an anatomical position in your pelvis until a prolapse happens. And when, for instance, the bladder prolapses and falls inwards into the vagina and causes a bulge, it's pulling the bladder out of its normal position. And that causes a kink in the tube coming out of the bladder. And so it will often interfere with the bladder's ability to work as well as it's supposed to work. And it can be a feature that women report to us, that they find it hard to get their bladder to start flowing and emptying. Sometimes people feel that their bladder is empty and they stand up, walk away from the toilet, and they feel, oh my goodness, I have to go straight back again. I'm not able to empty it completely. And we'll often start to get messages being sent to them to go more often, because they're getting trapped urine in the little U-bend of the kink in the tube. It's a little bit like stepping on a hose pipe. You get a little entrapment of the urine in the U-bend, and that is stimulating you to go. And yet when you sit down, you can't pass very much. There's only a little small amount comes out. So you can often hear this being reported when patients start talking about how the prolapse is affecting them. So then for women who've had, for instance, a childbirth injury, where the pelvic floor has been really overstretched. They may have had a very long labour. They may have had a forceps delivery. They may have had a very big baby that has a massive impact on straining the pelvic floor. They may also find that the support behind the bladder neck area has become very floppy. And that leads to an inability to have good control over the urine flow. So when you cough or sneeze, the urine starts to leak.
And Gráinne, you can, as a physiotherapist, can you help women with incontinence issues?
Yeah, there's a lot you can do as a physiotherapist. It's actually the first line of treatment as recommended by our guidelines, medical guidelines. So depending on what type of incontinence they have, the treatment for physiotherapy can vary. So we will work with, as I mentioned, the pelvic floor in strengthening the muscles, but also before that, we need to know whether that lady has a stress urinary incontinence or an overactive bladder or an urgency picture. So they would all be slightly different. So a stress urinary incontinence, any incontinence is an involuntary leak of urine. And typically stress incontinence would be when the lady would leak with coughing, sneezing, laughing or exercising. And this can often be as a consequence of, as Dr. O'Neil mentioned, a difficult childbirth, which would be one of the most common reasons, where there's damage to the muscles and also the elastic tissue underneath that. And really what we're doing in physiotherapy is trying to improve the muscle tone to help keep that tube called urethra that the urine exits, to try and support that better so you can close off that tube when the lady is coughing or sneezing or laughing, as an example.
These traditionally known as the Kegels.
Yeah, so they would be Kegel exercises and they would be predominantly to strengthen the muscles. But we also will evaluate the lady first to see whether it is that muscle is weak or whether that muscle is overactive. So with an example, that stress incontinence picture I was mentioning, it's not always that the lady has a weakness in that muscle or a low tone muscle, which we would call. Sometimes they can have the opposite, which is a high tone muscle. And this would be more likely seen in the athletic population where the pelvic floor is actually overworking to a certain degree. So you would talk about Kegel exercises strengthening the muscles, but what's really crucial is that person has had an evaluation internally first. It's not a bad position to start doing Kegel exercises in an attempt to try and help your symptoms, but it is preferable to evaluate it first, and then we'll be able to point you in the right direction as to whether you need that muscle to train more or that muscle group to train less, depending on the incontinence that they have.
Great. And Cheryl, just bringing you in here, I know sometimes physiotherapy unfortunately can't solve the problem, but there are things that you do as a specialist nurse in this area in terms of pessaries. Can you tell us what they are and what can be done in terms of pessaries for women with a pelvic prolapse?
As Gráinne said, the first line of treatment for prolapse is conservative management, and this includes managing the women with pessaries. There are different kinds of pessaries, but when we are talking to our patients, we need to ask them if they're still sexually active, because it will affect what type of pessary we use. And like Gráinne said, for stress urinary incontinence, if they have that, it will also guide us to the type of pessary that we use.
Okay, so let's talk about the incontinence pessaries. Tell us about those and how they're used and who can put them in.
There's what we call the ring pessary. So if you have stress urinary incontinence, there's a ring pessary with a knob that we can use to see if this would help with their stress urinary incontinence. There's also a folding ring pessary, which if the woman has good dexterity and is younger and is interested to self-manage their pessary, we can teach them to use the folding ring pessary.
And they can insert it themselves and take it in and out, maybe around sexual intercourse and
they
things
don't
like that.
necessarily need to remove the ring when they have intercourse, but they can be given that option to take it out.
And so that's for incontinence, but there are also pessaries for prolapse. Can you tell us about those? Who puts those in?
So we run a nurse-led pessary clinic here in Tallaght University Hospital, where we first of all assess how bad the prolapse is, and we start off with what we call a PVC ring pessary, because it takes about at least 3 trials before we get the size right. And we have to inform the patients of this because they do get upset when the ring falls out when they're straining or when they're walking or running. Once we get the size size right. If they're interested in self-management, we move on to the folding ring. If they have had a hysterectomy and they have a bladder or a bowel prolapse, we have a pessary that's called the cube pessary, which is also a self-managing pessary. So we teach them how to put it in and take it out. With the cube pessary, they have to take it out every day to prevent them developing infection.
And does it relieve that symptom of the bulging, of the fall in the kind of lower tummy area?
Yes, it does. It works very well for women. So basically what the pessary does, it brings the organ that's prolapsing back up to where it should be. And a lot of our women prefer not to go the surgical route, especially the older population or a woman who's younger but has not finished having their family yet.
And is it sore to insert this and to take it in and out, I suppose?
It's uncomfortable, and we explain this to the women, and we use a lubrication gel to help put it in. As well as that, there's a condition called vaginal atrophy in postmenopausal women. So if they have this condition, we do treat them first with a local estrogen called Vagifem that they can self-manage at home. And then
that's like a gel, is it, Cheryl?
There is a pessary form or there's a cream form of it.
And it just makes it easier to take in and out.
Yes, especially for the postmenopausal women, because if you think about it, once you're postmenopausal, you don't produce estrogen anymore, and the Vagifem just helps replenish estrogen inside the vagina.
So lots of good options, but sometimes, Aoife, women still need surgery.
Absolutely, Nolene. And our guidance around that is really related to how bothersome the problem is. Because whenever you do any operation, you have to consider the fact that you want the operation to give benefit to the patient without causing too many complications. And when it comes to doing prolapse surgery, the kinds of things that can happen when you're having an operation include things like infection after the operation. You could get a bleeding problem because some people who have prolapse may have to have a hysterectomy as part of their prolapse repair. And so you've got to remove and disconnect the uterus from its blood supply, which could cause a risk of bleeding or hemorrhage. You've also got a small risk of bladder injury and a small risk of bowel injury, depending on which area of the vagina requires the prolapse surgery. And those are the kind of typical complications that can come with prolapse surgery. In addition, then, I would always talk to patients and explain to them that there isn't really any one single operation that can guarantee that you won't get prolapse again in the future. And that's really important when you're considering and talking to women who are of an age that they still wish to continue to have children and aren't finished having their family. Because if you are committing someone to having surgery for their prolapse and you're going in to repair damaged tissues, clearly if they go on to have a pregnancy or a childbirth after that, it's going to really jeopardize the repair that has been done. And that makes it much more challenging to try and correct surgically down the line after that. Because you've already done surgery in that area. It makes it much more challenging to do another operation.
So it may be that if a woman is still wants to have more children, that it might make more sense to use the pessaries, and then when she's finished her family, then look at surgical options if that's what she wants.
Correct, exactly. So we have to tailor the advice and the options for management to the patient in front of us. To the woman who's suffering from, so if you have somebody that's really having significant bother from her prolapse of her cervix, for instance, and she can't even have an intimate relationship with her partner, and she's still very young and they still want to have more children, you may have to think about a surgical solution for that, where you know that it's not going to be likely to last in the long term because she's planning to have more children, and therefore there will be more strain on that part of the pelvic floor that you've gone to the bother of fixing. But
to allow her to get pregnant.
What can you do? Yeah, absolutely. She has her life to live with her partner, so we have to tailor the advice and we have to tailor the options to each specific person in front of us.
On a case-by-case basis.
Correct, yes.
Any final piece of advice for women, Aoife?
I think it's such a common problem. We see so many women coming to us with a prolapse problem, and it may be very mild, it may be more severe, but there is no reason for embarrassment. It's very important that if you have a sensation of a bulge down below, to get it looked at, speak to your GP, ask for advice about it. Particularly in the older age group, it's much more common in the menopause age group because of the lack of estrogen in the tissues lose their elasticity and everything sags more. So it becomes usually more apparent once you go into menopause if you are developing a prolapse. The older age group in particular can be very embarrassed because culturally we haven't been trained in going to seek help about your intimate...
Women's issues?
Yes, exactly, your intimate side of life. Or your vaginal problems, and that's often a source of embarrassment. But there are so many women's health doctors, nurses, physiotherapists that have so much experience looking after women of all age groups, and we always think that could be our mum or our sister. So there shouldn't really be any embarrassment, and we can always talk to the patient that's worried about the embarrassment or worried in any way, shape or form, and talk them through what we would do. It's a little drastic to explain this in a podcast, but this is our health we're talking about. It's how to work with each other to make sure that we optimize what we can to help us manage the problem that we're dealing with. And so I would encourage anyone that has any gynecological concerns to seek help.
So Cheryl, any final advice?
My advice is for women to seek help first and foremost, as Dr. O'Neil has said. And me explaining pessary over podcast might have scared a few women out there. But in Tala University Hospital, we cater to over 800 women with this problem. Women come in different shapes and sizes, and so does the pessary. So if your first pessary did not work, please come back or please seek help from your GP. We would be willing to try anything to make your quality of life better.
And a pessary is really just a device that you insert inside the woman to hold up the organs that might have fallen down. Is that correct?
Yes, so like I said earlier, there are different kinds of pessaries, and depending on where a woman is in their stage of life, whether they're sexually active. So this gives women who are still sexually active still a chance to have their intimate life back. And we have seen a few hundred women who have been very happy with their pessaries, as well as their partner being very happy, initiating their intimacy again.
And so it doesn't mean, and for some women, it means that the pessary solved the problem. There's no need for surgery?
Yes, there have been a lot of women who initially came to our clinic wanting surgery, but because the pessary has been working very well for them, they have declined surgery, and they have been coming over 10 years to our clinic.
Wonderful. And Gráinne, any final advice?
I think prevention is key, and it is really important that women of all ages, from post-puberty to your last years, complete pelvic floor exercises, if possible, daily. And again, you know, if that's not, it's never too late. Even if the lady hasn't been doing her pelvic floor exercises, it's never too late to start. We always say in clinic that urinary incontinence is incredibly common, but it's not normal. And we shouldn't be normalised leaking in our culture. We should be really striving to keep women dry from birth to death. And it's important that women know that there are resources out there for them, even if they are on waiting lists to see physiotherapists. There are resources there online. There are apps. There's a great app known as the Squeezy app that the NHS devised, and it's €3 on iPhone or Android. And it's a really good visual tool to get women to start training their pelvic floor while they're waiting to see a physiotherapist or a gynaecologist. So really the key message is it's never too late, and it's important to encourage at early ages that pelvic health is really important and pelvic muscle training is really important throughout their life.
And we'll put a link for that app in the description box.
Yeah, there are many resources out there for women to access information to help train their pelvic floor. And it's really important that we really promote women's health from early years until later years in life.
And you've explained very well, all three of you today, that there are lots of options available for women who have this problem. So thanks very much. So that's it for our third episode of this podcast series. Thanks to our experts, Consultant Gynaecologist Dr. Aoife O'Neil, Specialist Physiotherapist Gráinne, and Cheryl Gilmore, an Advanced Nurse Practitioner in Women's Health. Our next podcast will look at how women can best protect the health of their heart and bones. This Let's Talk About Women's Health series has been brought to you by Tallaght University Hospital. These podcasts have been kindly supported by the Healthy Community section of South Dublin County Partnership.